Welcome to STEM Talk.
STEM Talk. STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Welcome to STEM Talk, where we introduce you to fascinating people who passionately inhabit the scientific and technical frontiers of our society. Hi, I'm your host, Dawn Carnegas, and joining me to introduce today's podcast is the man behind the curtain, Dr. Ken Ford, IHMC's director and chairman of the Double Secret Selection Committee that selects all the guests to appear on STEM Talk.
The committee has been meeting day and night, I tell you, to sort through the many wonderful nominations.
It's a lot of work.
It is. But all votes have been unanimous. Dawn, it's great to be here today with you. And today's guest is Dr. David Spiegel, the Willson Professor and Associate Chair of Psychiatry and Behavioral Sciences at the Stanford University School of Medicine. He is also one of the nation's foremost hypnotists and was featured last year in a Time magazine article about how hypnosis can help people quit smoking and relieve chronic pain.
Yeah, our talk with Dr. Spiegel was definitely fascinating. We covered a lot of different potential conditions where hypnosis could be used for treatment. But before we get to today's interview with David, we have some housekeeping to take care of. First, we really appreciate all of you who subscribe to STEM Talk, and we are especially appreciative of all the wonderful 5-star reviews that are piling up on iTunes. As we announced in several earlier episodes, the Double Secret Selection Committee has been continually and carefully reviewing the iTunes reviews with an eye towards selecting the wittiest and lavishly praise-filled reviews to read on STEM Talk. As always, if you hear your review read on STEM Talk, just contact us at stemtalk@ihmc.us to claim your official STEM Talk t-shirt.
Today, our winning review was posted by someone who goes by the nickname the Agora Projects. The review is titled Essential Information, and it reads, "This is what I call the bomb of podcasts. So informative and essential in so many areas of science, nutrition, and health. Thanks, guys, for doing the research and making it available to us mortals."
Well, thank you so much, Agora Projects, and thank you to all the other STEM Talk listeners who have helped STEM Talk get off to such a great start.
Okay, and now on to today's interview with Dr. David Spiegel. In addition to his role as the Associate Chair of Psychiatry and Behavioral Sciences, Dr. Spiegel is also the Director of the Center on Stress and Health and the Medical Director of the Center for Integrative Medicine at the Stanford University School of Medicine. He has more than 45 years of clinical and research experience studying psycho-oncology, stress and health, pain control, and hypnosis.
David earned his bachelor's degree at Yale College and graduated from Harvard School of Medicine in 1971. He has published 12 books, including one with his father, who was also a psychiatrist and practicing hypnotist. He has written more than 380 scientific journal articles and 167 book chapters on topics ranging from hypnosis to psychosocial oncology to trauma to psychotherapy.
His research has been supported by the National Institute of Mental Health, the National Cancer Institute, the National Institute on Aging, and the National Center for Complementary and Integrative Health, the John D. and Catherine T. MacArthur Foundation, and the Dana Foundation for Brain Sciences. He is the past president of the American College of Psychiatrists and the Society for Clinical and Experimental Hypnosis, and is a member of the National Academy of Medicine.
STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Hi, welcome to STEM Talk. This is Dawn Carnegas, your host, and I'd like to welcome today Dr. David Spiegel. David, welcome to the podcast.
Thank you. Glad to be here.
And also joining us today is Dr. Ken Ford.
Hi, Dawn, and hello, David.
So, David, let's start off with your background. I understand that both of your parents were psychiatrists and that your father had actually started practicing hypnosis just before World War II. So was it always your plan to follow in your parents' footsteps?
Well, Dawn, my parents told me I was free to become any kind of psychiatrist I wanted to be. I took them up on it. The dinner table conversations were very interesting. And I, of course, tried to be all kinds of other things. I was a philosophy major in college. I thought about teaching philosophy, and I thought being a great philosopher would be one of the best things to do with a human life. And teaching freshmen Plato your entire life would not be. And I kept being interested in how the mind worked, and I found that philosophy was a way to think more broadly about that. And I went to medical school and thought about being a surgeon or an internist, and I just kept getting drawn back to psychiatry. So I couldn't escape it, so I decided to join it.
You were just drawn in. So you mentioned that you got your Bachelor of Arts in Philosophy, and then you headed off to Harvard Medical School. So why did you decide to specialize in hypnosis?
Well, I took a course there. Tom Hackett, who was chair of psychiatry at Mass General, was teaching a course. It was fascinating, but I can tell you the day that I made the decision, turned out to be a life decision. I was working at Children's Hospital, and the nurse told me, your next admission is in room something or other, and I was just following the sound of the wheezing down the hall. And she was a 16-year-old girl, bolt upright in bed, knuckles white, couldn't breathe, mother crying. She had been twice unresponsive to subcutaneous epinephrine. The next step was going to be general anesthesia. And I had started this course. So I said, do you want to learn a breathing exercise? And she nodded. And I got her hypnotized. And then I realized we hadn't gotten to asthma in the course yet. So I came up with something very clever and profound. I said, each breath you take will be a little deeper and a little easier. And within 5 minutes, she's lying back in bed. The asthma attack is broken. She's not rubbing her hands together. Her mother stopped crying. The nurse ran out of the room and filed a complaint with the nursing supervisor that I had violated a non-existent Massachusetts law by hypnotizing a minor without parental consent, even though the parent was in the room. And so my intern told me I had to stop using hypnosis with the patient. And I said, why? He said, well, it could be dangerous. I said, well, you're going to put her on steroids. You were going to give her general anesthesia, and you call this dangerous? And he said, well, you won't be able to keep treating her. I said, I'm in Boston, and I'll see her as long as she wants. So he said, well, you're just going to have to tell her you can't do it. And I said, I'll tell you what, you can take me off the case if you want, but as long as she's my patient, I'm not going to tell her anything that isn't true. And she knows it's helping her. And so there was a 3-day fight among the attending and the intern and the chief resident. And they came up with a radical idea. They said, let's ask the patient. I don't think that had ever been done before at Children's Hospital. And she said, oh, I like this, because she'd been hospitalized every month for 3 months in status. Mm-hmm. She had one subsequent hospitalization, wasn't hospitalized since, and for a while went on to study to be a respiratory therapist. And I thought that anything that can help a patient that quickly, that much, violate a non-existent Massachusetts law had to be worth looking into. And so it was that moment when I decided, all my classmates are using the latest drug that was reported in the New England Journal that week. And I was doing something that other people didn't seem to know much about. So I decided to make that my life's work.
It was shortly after you graduated from Harvard Medical School that you made news for undergoing a 3-hour surgery on your shoulder and refusing pain medication. That's utterly amazing to one who's had some shoulder surgery. Can you talk to us about that?
Well, I should explain. It was a 3 hours, a Bankart repair of my shoulder. I had recurrent dislocations in my shoulder, and Carter Rowe at Mass General did it. During the procedure itself, I had general anesthesia, but...
Oh, good.
Yeah. No, I'm adventurous, but not crazy.
Yeah, I'd say you're my hero.
Although I should say that my wife Helen had both of our children with hypnosis as the sole anesthesia, and I had no pain at all. And she did great. Dan was 10 pounds when he was born. It was a 12-hour labor.
Wow.
She did fine. But so after the procedure, I was using no pain meds at all. I was doing self-hypnosis. And I went and read my chart. I wasn't supposed to, but I worked at the Mass General. So, I opened my chart and the resident wrote, patient using very little pain meds, we mustn't have cut many nerves. Well, I can tell you there are plenty of nerves cut, but that's the way in which people in medicine have thought, bottom up, not top down, that we have this brain on our shoulders for a reason. And one of our adaptive advantages is to be able to modulate pain perception, and that's what I was doing.
That's really cool. So just to kind of give us an overview of what hypnosis is. So most everyone's familiar, at least on a passing level, the concept and have seen it portrayed in movies or on TV shows, but very few of us really have a sense of what it actually is. So for our audience, can you explain in broad terms what hypnosis is, what the applications might be, as you've kind of been talking about already, and perhaps talk about some of the neurophysiological mechanisms that underlie the process?
Sure, I'm glad to. Hypnosis has been called believed-in imagination. It's something like the experience you may have getting so caught up in a good movie or a novel that you forget you're watching a movie or reading the novel and just enter the imagined world. It's the equivalent in consciousness to what a telephoto lens is in a camera. What you see with great detail. but you're less aware of the context. And so it allows you to concentrate very intently, but also to put aside other preoccupations or questions or doubts that might keep you from fully engaging in the immediate experience. It's used commonly to treat problems like pain, stress, anxiety, phobias. We use it to treat post-traumatic stress disorder. It's a very helpful way of regulating mind-body interactions. So patients with what are called non-epileptic seizures can be helped a great deal with it. People with irritable bowel syndrome get significant relief. So it helps not only with subjective symptoms, but with some physiological symptoms as well. In terms of what's underlying it, we've done some research recently that shows that three things happen. We've used functional magnetic resonance imaging, and we've shown three things happen when highly hypnotizable people are hypnotized. One is they turn down activity in a part of the brain called the dorsal anterior cingulate cortex. It's a part of the salience network that tells us what to worry about and what to ignore. If air traffic controllers have three planes converging on one runway, their anterior cingulates should be firing away. Hypnosis, you turn it down. You just are less likely to contrast and compare, to worry about what else you might be doing. There's higher functional connectivity between the executive control region in the brain, the dorsal lateral prefrontal cortex, and the insula, which is a part of the brain that is a pathway for mind-body control and for pain perception. So you're enhancing your ability to connect your brain with your body. And there's inverse connectivity between that executive control region and what's called the default mode network. It's a deep part of the brain that is active when you're just ruminating, thinking about yourself, wondering about yourself, not doing a task. So it's a kind of basis for the dissociation you see in hypnosis, where you're able to focus on one thing and disconnect from your self-awareness of doing it or from other things that might interfere.
That's a great overview. Thank you. Many aspects of hypnotism and mindfulness actually sound similar. So, for instance, you have said that hypnosis involves a non-judgmental awareness, which is similar to how mindfulness is often described. So how are these processes similar and how are they different?
It's a very interesting question, and we're studying it now. We're analyzing data, comparing the findings I talked about with hypnosis to what we see in mindfulness. Mindfulness tends, of course, it's Eastern, and so it being out of an Eastern tradition, it tends to be less sort of pragmatic and problem-focused. So if you use mindfulness for pain, you don't directly try to influence the pain perception. You try to what's called surf the emotion. You just kind of let it flow through you, and without judging it or resisting it or fighting it. There is some focal attention in mindfulness in techniques like the body scan, where you step by step pay attention to different parts of your body. What is somewhat different in mindfulness is that much of mindfulness training involves compassion awareness, trying to imagine compassion for other people, even people not related or connected to you in some formal way. So I would say mindfulness uses some similar techniques, but the mind neuroimaging studies tend to show reduced activity in the default mode network, particularly the posterior cingulate cortex, which is not something we see typically in hypnosis. And they have increased activity in the left frontal pole, which tends to elevate mood. So there are similarities, but there are also differences. In a practical way, hypnosis is something you can learn to use for 5 or 10 minutes 4 times a day, or whenever you're feeling pain or stress or anxiety or want to go to sleep. Whereas mindfulness is meant to be practiced, half an hour twice a day, and is not directly focused on eliminating or reducing a symptom.
Continuing with mindfulness, are those that are easily hypnotized, and we'll come back to ease of hypnotizing folks, but are those that are easily hypnotized also more likely to be able to successfully practice meditation or mindfulness, or is this something we just don't know?
Well, it hasn't been studied in a formal way. My experience with my patients is that people who are moderately to highly hypnotizable find mindfulness a snap. It's very easy for them to just drift into it and do it. And the ones who are not hypnotizable have to work at it a lot more. I sometimes find mindfulness a useful alternative for people who just can't use self-hypnosis. But I do think there's an overlap, and the people who are highly hypnotizable find it easier to engage in this altered state of consciousness that you see in mindfulness.
David, I'm kind of curious from a research feasibility standpoint. I have colleagues who are interested in studying mindfulness for conditions such as PTSD or pain management, but they've had trouble finding funding on those topics. So who typically funds the work that you do?
Well, currently, my two grants, and one is explicitly a hypnosis grant, is from the National Center for Complementary and Integrative Health. And they're a relatively small institute, but an institute of the National Institutes of Health. And they are very interested in techniques like hypnosis and mindfulness, other integrative approaches, acupuncture and other things, particularly as they relate to physical outcomes. So I would encourage people who are interested in studying that to contact the NCCIH.
That's great. That's very helpful. So you've written about how hypnosis is the oldest Western conception of psychotherapy. So can you give us a short historical tour of hypnosis?
Sure. I mean, it's kind of odd but it's true that it's the first time in Western tradition that a talking interaction between a doctor and a patient was thought to have therapeutic possibilities. It began with a Viennese physician named Franz Anton Mesmer in the 18th century. He called hypnosis animal magnetism, and he would take patients who had what we would now call often hysterical symptoms, put them next to what he called a paquet, water filled with iron filings and a weak magnetic field, and they would often swoon and come out of the state feeling some difference in their symptoms. And so he became rather successful, left his wife and family in Vienna and moved to Paris around the time that Benjamin Franklin was there. And he became the go-to celebrity doctor for the upper class in France. And if you think about it, if you did a randomized clinical trial and sent every other patient then with a medical illness, either to Mesmer or a French physician, who do you think would have better results? You want to take a guess?
Mesmer.
Yes. Why?
Because he was directly affecting their perception of the outcome.
That's half the answer, but the other part is what the French physicians were doing at the time, which is mostly bloodletting.
Yeah, leeches.
Leeches. France was the world's leading exporter of leeches. Voltaire wrote to his brother, "We did everything we could to save father's life. We even sent the doctors away." So this did not win him a lot of friends in the medical community, and they convinced King Louis to convene a panel of experts that included Benjamin Franklin, the brilliant chemist Lavoisier, and Dr. well-known for his work in pain control, Dr. Guillotin, the inventor of the guillotine. He kind of created the mind-body problem. And
what a government panel.
They concluded that hypnosis was nothing but heated imagination. And in some ways, they were probably right, but it was a devastating conclusion for Mesmer, and that was pretty much the end of his career. The interesting thing is that hypnosis, I think of it as something like the oldest profession. Everybody's interested in it, but nobody wants to be seen in public with it. Freud started his career learning hypnosis from the great French neurologist Jean-Martin Charcot. And if you read the studies in Hysteria, it's all about hypnosis, using hypnosis to help patients eliminate pain and anxiety and other symptoms. And he wrote in his autobiography that he was using hypnosis to relieve a patient of her pain by tracing her attacks back to a traumatic origin. When she woke from the trance and threw her arms around my neck, he said, "I was modest enough not to attribute this event to my own irresistible personal attractiveness." And so he decided it was necessary to eliminate hypnosis because he discovered transference, the idea that patients transfer feelings from important people in their lives onto their therapists. So he moved, there's a couch in analysis because he was using it to induce hypnosis. He moved his chair around behind it because he didn't like patients staring him in the eye, and they were now going to be eyes open, free associating. But at the end of his career, I happened to be at his last office in London, where he saw to the arrangement. And in the Vienna office on the Bergasse, he had a picture of an archaeological dig over the couch, the sacred spot over the couch, which made sense because he's interested in deeper and deeper levels of the unconscious. At his last office, he had a picture of Charcot demonstrating hypnosis. And he wrote that he thought the pure gold of analysis might have to be alloyed with the baser metal of suggestion. So Freud, at the end of his career, got interested. Most psychoanalysts did not follow him in that way. And one other example is that there was a woman who was treated by a disciple of Mesmer's named Phineas Quinby. She had spinal weakness, had to be carried around by her father up into her 20s through her marriage. And finally, when she got pregnant, she decided this was enough. And she went to see Phineas Quinby, who cured her of her spinal weakness. They started corresponding. Some speculate they had an affair. 5 years later, she got a letter informing her that he had died suddenly. And the next day, she slipped on the ice. She re-injured her back, went into a period of mourning, and decided that it was not animal magnetism that had cured her. It was the Word of God. And that was Mary Baker Eddy. And so hypnosis, we owe to hypnosis both psychoanalysis and one of the few remaining newspapers in the United States. And yet what often happens is people are interested in it and then they move on to something else. So in the 20th century, there were people like Milton Erickson who carried on the tradition, and then my father, Herbert Spiegel, started working with it. He learned to do it in his training to be a battalion surgeon in World War II. And more research has been done, and a lot more people have been using it.
That's a fascinating history. So I want to talk a little bit about your history now. So you've had more than 40 years of clinical and research experience studying hypnosis and psycho-oncology, pain control, psychoneuroendocrinology. And some of your first studies involved the use of hypnosis in the treatment of post-traumatic stress disorder, otherwise known as PTSD. And you were involved in 2 studies specifically that showed Vietnam veterans with PTSD had higher than normal tendencies to be hypnotized. So can you tell us about those studies and also the utility of hypnosis as a treatment for stress and physical trauma?
You know, the essence of trauma is helplessness. It isn't pain, it isn't fear. It's that for a certain period of time, and usually suddenly, you lose control over what's happening to your body, and that's a terrifying thing. And many people cope with that in the short run by detaching themselves from their bodies. I have patients who were sexually abused as children who said, I would just go to a mountain meadow of wildflowers and count the flowers, and, whatever happened to my body happened to my body. Most rape victims will tell you that they experienced the rape as if they were floating above a woman who was being raped, feeling sorry for her. So dissociative defenses happen during trauma, and so it makes sense that mobilizing in a controlled way the dissociation can be helpful. And one of the things we did, as you mentioned, is we studied populations with PTSD, with schizophrenia, with depression, normal subjects, and found that the patients with PTSD were by far the most hypnotizable group, twice as hypnotizable as people with schizophrenia, for example, and higher even than normals. And it suggests that there is a role of spontaneous self-hypnotic experience during trauma and also in the symptoms afterwards, like a flashback, in which you don't just remember the trauma, you relive it as though it were happening again, meaning with all the uncertainty about whether or not you survived the attack afterwards. There's dissociative amnesia that's a symptom of PTSD, where you were conscious when the trauma happened, but you can't consciously remember it afterward for some period of time. Mm-hmm. So it made sense to me that mobilizing a technique that was similar, but you could do under controlled circumstances. The key issue is to help to do it in modulated ways and make the patient feel in control of how much they want to deal with at any one time, and then to help them restructure the experience. So I had a rape victim an attempted rape victim who fought vigorously with her assailant. He left her with a basilar skull fracture, but she wasn't raped. And she wanted me to help her try and identify what he looked like, because the police, once they learned she wasn't raped, were kind of lost interest in the case. And she realized in hypnosis, as she looked at his face, she said, he doesn't just want to rape me, he wants to kill me. If he gets me upstairs, he's going to kill me. And then I said, well, what did you do to protect yourself? And she said, he's surprised that I'm fighting that hard. He didn't think I would. So on the one hand, hypnosis helped her to realize that it was even worse than she thought it was, on the one hand. And on the other hand, that she had done something that probably saved her life. She'd been feeling guilty that she got herself so badly injured. So hypnosis can be very helpful in dealing with the symptoms, controlling the physiological reaction, because often when we think about something arousing, we get physically aroused. But you can, in hypnosis, dissociate your level of physical arousal from your level of mental arousal, and then think about it from a new point of view, restructure your memory and understanding of the traumatic experience. And that can make it a very useful tool in treating PTSD.
So have you, in your own experience, found hypnosis to be an effective treatment for PTSD?
Yes, and there is one randomized trial that I didn't conduct, but a guy named Danny Brum from Israel did, showing that hypnosis produces significantly better results in treating PTSD, then some comparison psychotherapies that also work. So, and in my experience, yes, it's very helpful.
We've discussed hypnosis and its efficacy for PTSD. What about phobias?
In a sense, phobias are a kind of spontaneous, hypnotic-like experience in which you exaggerate your fear about, driving on a freeway or crossing a bridge or getting on an airplane. And the possibility becomes a probability. The fact that you can picture some bad outcome makes you increasingly convinced that the bad outcome will happen. And then the more you avoid it, the more you associate the thing you avoid with the worst possible outcome because you don't have any normal experience with it. And so I find that it's very helpful to teach people how to use self-hypnosis to manage their physiological anxiety. They just imagine they're floating somewhere safe and comfortable, like a bath, a lake, a hot tub, or floating in space. And then for an airplane phobia, for example, I'll teach people while they're doing that to picture themselves floating with the plane, so the motion of the plane doesn't have to be upsetting. It can be like a ride on a roller coaster. Thinking of the plane as an extension of their body. So rather than feeling trapped in a tin can, they see the plane as sort of like a bicycle. If you want to get somewhere faster, you get on the bicycle because it's an extension of your body. And in the same way, you choose an airline that has well-trained pilots, and they are an extension of your body. So you're still in control, even though you're in the plane. And the third is to think about the difference between a possibility and a probability. It's always possible the plane will go down, but it isn't likely. It's possible there'll be an earthquake right now, and this building will come down on me, but it's not probable, so I don't worry about it much. So we teach people to practice that before the flight. When they get on the plane, they can stay in the state the whole time. And we found that half the people I treat with one session like this will be improved or cured. And I get messages from around the world from people who made it.
That's great. You touched on this earlier in a different context, but can hypnotherapy be used to reveal suppressed or impaired memories? And you sort of talked about it a little in the context of rape, but to enhance memory of trauma, which tends to be impaired because retrieving the memory itself produces an effect or panic that can sort of interfere with the retrieval process. Has hypnosis been used to enhance eyewitness memory, and do the courts regard it as kosher?
Well, it has been used that way. It's been misused that way too. And in general, the courts raise questions about it. In California, the Supreme Court passed a ruling called People versus Shirley that basically says if a witness or victim is hypnotized, they cannot testify. But the legislature passed a law that says if it's done according to certain guidelines, which include an independent professional, so not a police officer, but a psychiatrist or psychologist, nobody else in the room, video recording of all contact with the subject so you can determine whether there was influence, undue influence. So rather than saying, did you see the 7-foot black man when he pulled the knife, rather than say, what did you see when you were assaulted? So you're not implanting information, you're trying to elicit information. The research tends to show that you get more information with hypnosis, that your rate of accuracy is not better or worse, but you tend to be more convinced that what you're reporting is correct. So courts are understandably concerned that they'll have a witness who's invulnerable to cross-examination. But, there are lots of things that will influence a witness, like if somebody threatens to kill them if they say something. So good courts have said, take it into account, examine what they did, and there are circumstances where hypnosis has added information. So, for example, there was a Chowchilla school bus kidnapping, you may remember that, where a whole school bus of kids was hijacked, kidnapped, buried underground, and they finally found the bus and released the kids. The key clue to the assailants was hypnosis of the bus driver, who was able to picture under hypnosis the license plate of the car that overtook the bus. He got all the numbers and letters right, but in the wrong order. And that led to the arrest and conviction of the people who did it. So there are times people do suppress recollection because recalling things is emotionally very painful. And so there are times when you can provide that additional comfort and access that allows them to recall things that they previously couldn't recall. But there are risks, as there are with any interrogation procedure.
There was a landmark study published in the journal Science in the late 1990s by Pierre Rainville of the University of Montreal The study looked at hypnotized people who placed their hands in really hot, painfully hot water. Many have said that this study changed the whole landscape of hypnosis and other such comments. Could you talk to us about this study and its importance?
Pierre Rainville is an excellent researcher, and he and his colleagues added to a growing body of literature that showed that when people use hypnosis to alter perception, they don't just record the perception the same way and tell you it's different. They actually change the way they perceive things. And so the science paper and a related paper showed that if you give people painful stimuli and hypnotize them and tell them one kind of instruction, and I think this was the one in the science paper, your hand is in circulating ice water, it's cool, tingling, and numb. You reduced activity in somatosensory cortex. So their brains were acting as though they were feeling something different from what they reported when they weren't doing the hypnotic analgesia. He did another study, it was very interesting, in which he did the same thing, except the hypnotic instruction was different. He said, there's some pain there, but it won't bother you, which is sort of the way people feel when they take opiates. And there they got pain control, but it was reduced activity in the anterior cingulate gyrus, what I mentioned earlier as being related to hypnosis itself, reducing concern about sensation. So it was a clear demonstration that when you hypnotize people, they literally alter what they perceive. They don't change the way they react to what they perceive, and that was very important.
Interestingly, not everyone can be hypnotized. You've used functional MRI scans to figure out why some people aren't susceptible to hypnosis. In a 2012 paper about those brain scans, you shared the results of a study that showed hypnosis actually changes the way blood flows to different areas of the brain. You reported finding a drop in activity in part of the salience network you mentioned earlier, the dorsal anterior cingulate, in people who could be hypnotized. Can you share with us again, in a little more detail, the importance of that finding and what it revealed to you?
Sure, Ken. Well, there are actually two studies involved, and you're right. In the 2012 study, we were asking a slightly different question. The question was, is there any detectable difference using functional MRI in the brains of people who are highly hypnotizable versus people who are not at all hypnotizable? So we tested people and found those on the extremes of hypnotizability. And we found something, and we just put them in the scanner and just asked them to rest and think about whatever they want to think about. We were not trying to hypnotize them in that study. And we found that only in the highly hypnotizables was there enhanced what we call functional connectivity between the executive control region in the brain on the left, the dorsolateral prefrontal cortex, and the salience network, particularly the dorsal anterior cingulate. So what this means is that at rest, people tended to coordinate activity in the part of their brain that plans and thinks and decides what to do, and the part of their brain that worries about what you should be doing. And it is consistent with findings of what's called higher levels of absorption in people who are highly hypnotizable. They're the kind of people who tend to get lost in a sunset or a good movie or a novel. And that would be consistent with having brains in which what you're doing is tied to thinking about what else you might be doing. And so it's easier for you to have this kind of self-altering attention or believed-in imagination. In low hypnotizables, we saw no special functional connectivity between the two. So it suggested to us that there are brain state differences between people who are highly and people who are not at all hypnotizable. Then in the second study, we looked at those regions and others to see what happens when people are actually hypnotized in the scanner. And there we saw reduced activity in the dorsal anterior cingulate, higher functional connectivity between the executive control network and part of the salience network, the insula, that connects the brain to the rest of the body and processes pain signals, and this inverse functional connectivity between the executive control network and the default mode network, the medial prefrontal cortex and the posterior cingulate, which is active when you're just resting and ruminating about yourself and who you are.
So you've also had previous research that has shown that hypnotizability correlates with dopamine levels in the brain. So does that mean that dopamine is a key driver of the ability to be hypnotized? And if so, why would that be?
We think so. Well, part of it is a lot of the brain regions I've been talking about, particularly the dorsolateral prefrontal cortex, the anterior cingulate, are dopamine-rich regions in the brain. Dopamine is a neurotransmitter that involves activation and reward. And certainly people are activated. Hypnosis is not sleep. It's highly focused attention. People are activated in it. And it's also involved in reward pathways. So you can easily feel good. Most of my patients are surprised at how good they feel when they are in and come out of a state of hypnosis. A patient with a lot of problems with migraine and other somatic symptoms last week, when she came out of about 10 minutes of self-hypnosis dealing with those problems, said, I feel like I've just awakened from a 10-year sleep. I feel great. So it makes sense that dopamine would be the mediating neurotransmitter for a lot of activity that's related to hypnosis.
So, David, is this effect of dopamine linear? So with those with the highest levels of dopamine being the most hypnotizable? And I'm asking this because you also found that those with a heterozygous COMT mutation were more hypnotizable than those with either a homozygous valine or methionine, which might suggest otherwise.
This is a bit of a complex question, but the earlier study that we did showed a significant correlation in the cerebrospinal fluid between levels of a dopamine metabolite, a homovanillic acid, and measured hypnotizability. So there we were saying overall it seemed that more highly hypnotizable people process more dopamine in their brain. Now, the genetic study was one I did not conduct. A colleague of mine, Pesach Lichtenberg in Israel, did. And there, the idea was looking at variants of the catechol-O-methyltransferase gene, which is in the dopamine metabolism pathway. And so it's not so much about levels of dopamine as it is which kind of dopamine activity do they have in their brains. And people who are heterozygous, valine methionine, tend to have more flexibility in the way they deploy attention than those who are homozygous for either one. And we think it's that attentional flexibility in the way their dopamine is utilized that is consistent with higher hypnotizability. It's sort of figure ground awareness, and the heterozygotes have more flexibility in attending to figure or ground than the homozygotes.
That's a great answer. I had been wondering, others had shown that those who are homozygous for valine with supposedly the lowest dopamine were the most hypnotizable, but I think you've sort of explained why could be the case.
Yes, I hope so.
STEM Talk is an educational service of the Florida Institute for Human and Machine Cognition, a not-for-profit research lab pioneering groundbreaking technologies aimed at leveraging and extending human cognition, perception, locomotion, and resilience.
We've been talking about dopamine, and that raises the question of Parkinson's. Can you talk a little bit about Parkinson's in the context of hypnosis?
I have used hypnosis to help people with various neurological dysfunctions, a bit with Parkinson's. I have a couple patients I've treated with Parkinson's and also MS. Because, there is an overall brain functional component that affects the expression of clearly neurological symptoms. So, for example, someone with somewhat limited mobility who can get around with MS, when they have to get on a city bus, they sometimes freeze because the social pressure to move actually inhibits their ability to use their muscles as best they can. So conversely, helping people to feel more relaxed and comfortable or perceive the situation differently can actually help them use whatever their limited neurobiological abilities are. So I think it has to do with kind of mobilizing the rest of the brain. Now, Parkinson's in particular, of course, is a dopamine depletion disease. I mean, we treat it with dopamine replacement. And it is also results over time, not only in the motor dysfunction that we see, the slowness of gait, the difficulty in initiating movement, but also in some cognitive impairment and depression. So as people get more advanced with Parkinson's, they often become less hypnotizable. But particularly in the early stages, hypnosis may be helpful in reducing the secondary anxiety and frustration that people with Parkinson's have.
I can see that would be the case. Mm-hmm. Is there a practical way to gauge whether someone will be receptive to hypnosis? Not a theoretical way or a lab approach, but when they're in your office looking at you?
Oh, sure. Well, I use a scale that my late father and I developed called the Hypnotic Induction Profile. It's a 5-minute standardized hypnotic induction with a series of challenges and questions afterwards that yields a rating from 0 to 10 and is a very reliable measure of hypnotizability. And I use it as a standard way of introducing my patients to hypnosis and educating me about how hypnotizable they are. And then I discuss the results with them. About 1 out of 3 people just aren't hypnotizable, and I tell them we're going to do something else. And then the rest are low, medium, or high in hypnotizability, and that helps me decide what approach to take in using hypnosis. I've probably used it, I figure, with 8,000 or 9,000 people in my career, both research subjects and patients.
Wow. Is it possible to change people's susceptibility to hypnosis?
In general, no. There have been studies in which they've tried to train people to respond better. And, you don't make a 2 into a 9. You can improve scores a bit. People will respond a bit better, but you don't fundamentally change it. Now, in collaboration with my colleague at Stanford, Nolan Williams, and with support from the National Center for Complementary and Integrative Health, we're doing a study in which we're using repetitive transcranial magnetic stimulation to alter those very systems that I mentioned, the connection between the dorsolateral prefrontal cortex and the dorsal anterior cingulate, to see whether we can enhance hypnotizability and response to treatment. And if I can put in a brief commercial there, we're recruiting subjects with fibromyalgia syndrome to see whether we can enhance their hypnotizability and their hypnotic analgesia, their use of hypnosis, to reduce their fibromyalgia pain. And so if anyone's interested, we can potentially fly people from other parts of the country for a one-day evaluation and intervention here. And the phone number is 650-723-5736. And we'll be glad to talk to them about that. We have one other study using fMRI for women who have been recently diagnosed with breast cancer, and that same number would work if they're interested in allowing us to help understand how they're making their treatment decisions. So within the first 6 months of their diagnosis with breast cancer.
That's fantastic, David. So let's talk about the non-believers. If someone doesn't believe in hypnosis, can they be hypnotized?
Yes, I'm glad to say they can. My father used to tell a story. He was studying it in World War II, and he had one person on the ward that he wasn't particularly interested in, and the guy stomps into his office and said, "Captain Spiegel, you couldn't hypnotize me if you wanted to." And my father had a pencil dot on a paper he was using as an eye fixation technique, and the guy's right eyelid closed. And my father said, "Well, then how come you can't open your right eye?" And he said, "Well, my left eye is open." And my father said, "Well, close that one too." And he was in a trance. So skepticism has very little to do with hypnotizability.
Interesting. And you'd also talked about your work in the Children's Hospital and how you initially got into hypnosis. So does it seem that children are more susceptible to hypnosis than adults?
Yes. The peak of hypnotizability in the human life cycle is the latency years in childhood, between about 5 and 10. All 8-year-olds are in trances all the time. You call them in for dinner, they don't hear you. They're out doing what they do. And it's part of why childhood is so wonderful. Work and play are the same thing. They get totally engaged and absorbed in whatever they're doing. And we sometimes spoil it by trying to make little adults out of them. It's better to just let them enjoy doing what they're doing. Throughout adolescence, as we develop what Piaget used to call formal operations, where we let logic supersede immediate experience, some people lose that precious ability to experience hypnosis. And by the time you're 21 or so, your hypnotizability becomes as stable as IQ. It's just a very stable trait.
That's really interesting. So you talked about self-hypnosis earlier. So how effective is that? And are there any notable limitations?
Well, one of the real advantages of hypnosis is using self-hypnosis. So my approach to patients is not to say, okay, you're going to have to come to me forever to have me continue helping you control your pain or keep you off cigarettes or whatever it is. I demonstrate to them how hypnotizable they are, use a hypnotic technique with them, and teach them how to do that for themselves. And these days, I have them record that part of the session on their smartphones so that they can play it for themselves if they don't want to just do it from memory. And so the bulk of my practice now is teaching people to use self-hypnosis to manage symptoms. And it's one of the real advantages. They've got it with them all the time. We did a randomized clinical trial of women with metastatic breast cancer We involve them in weekly group therapy that help them deal with their anger, fear, and sadness about the disease, form new relationships with other women with similar problems, detoxify their fears of dying and death, communicate better with family and physicians. And we taught them self-hypnosis for pain control. And by the end of the year, they had half the pain the control group did on the same and very low amounts of pain medications. And they would tell me if it started to hurt, I'd just do my self-hypnosis. So it's, I think, an especially useful tool because it's a skill that one can learn to use to manage your own symptoms.
Shifting gears and going back a little bit to something we touched on earlier, individuals that are homozygous for COMT-MET-MET, presumably higher dopamine, have shown in some studies to receive greater benefit from the placebo effect. Is response to the placebo effect associated with hypnotizability? And if so, are people that are easily hypnotized therefore more likely to benefit from any placebo effects of hypnosis? In other words, is that part of the benefit that one gets from hypnosis?
Yes, it's a very interesting question, Ken, and the answer is yes, but there was an excellent study done many years ago by McGlashan, Evans, and Orrin, in which they took low and high hypnotizable people and stuck their hands in circulating ice water and saw how long they could keep their hands in the water. So it's a good objective measure of how much pain they had. For the low hypnotizables, hypnotic analgesia and placebo effect were exactly the same. So it helped both of them somewhat. For the high hypnotizables, hypnotic analgesia was a whole lot more effective than placebo analgesia. So the issue here is that the placebo pathway, which includes some similar regions, the dorsal anterior cingulate, the insula, it may be mobilized, but hypnotic analgesia can do more if you are highly hypnotizable than placebo analgesia can.
And I know they said the placebo effect is unable to directly change underlying physiology. Is there any evidence that hypnosis can directly alter disease states themselves, or are we just changing how we experience them?
No, there is evidence. For example, a British internist named Horwell did a series of randomized controlled trials of using hypnosis to treat irritable bowel syndrome. And he found that not only did hypnosis reduce the amount of discomfort they had, but it changed their bowel habits. It changed how frequently they had diarrhea. So we did a study in which we measured gastric acid in a situation in which we had people come in first thing in the morning and eat imaginary meals. And we got an 81% increase in their gastric acid secretion. In fact, I had one woman, it was an hour-long thing. We were both very hungry. And after about 30 minutes, she said, "Let's stop, I'm full." This is eating imaginary meals. We then did it the other way. We said they were hypnotized and imagining that they were doing something pleasurable that didn't involve food or drink, like being on a desert island or something, or hiking. And there we got a 39% decrease in gastric acid secretion. So we could change gastric acid in either direction. And then we injected them with pentagastrin, which is a hormone that stimulates the output of gastric acid from parietal cells. And we still got a 19% reduction in gastric acid secretion after pentagastrin. So the answer is, and a lot of these brain imaging studies we've done show that you can alter color perception, you can alter pain. And it isn't simply, how you're reacting to it once you've recorded it. It's you change the way you experience the event.
That's really interesting. So Robert Sapolsky would say that dopamine is produced to provide motivation to achieve a goal, and it's even greater when the result is uncertain. So how does this view of dopamine tie in with the ability to be hypnotized? And are there physiological effects that are related?
It's a very interesting question. Robert Sapolsky is a colleague here at Stanford and a friend of mine, and we published a paper together in the Journal of the National Cancer Institute showing that loss of normal diurnal variation in cortisol actually predicts shorter survival with advanced breast cancer. So his work on stress and the neuroendocrine system is fascinating. He's right about dopamine. It's part of the mesolimbic reward system. It's what keeps people, and the interesting and tragic thing about opiate addiction is that people get more dopamine secretion in the reward pathway from searching for the opiate than they do from taking the opiate. And that's what keeps people hooked, is that there's something about the chase. It's sort of like people who are compulsive sexualizers. The object of their desire is interesting until they connect with them, and then they're on to someone else. So it is the case that intermittent positive reinforcement, reward seeking, is actually a highly pleasurable human activity. And I think we evolved that way to keep us looking for new things and not settling into routines that we had. Now, the interesting connection with hypnosis, I think, and part of why hypnosis is pleasurable, is that sometimes imagining a situation feels almost as good as experiencing that situation. And so you can use your brain to think about things that make you feel good, which can also offset. One theory about placebo analgesia is that you're activating pleasure centers and just reducing the attention you pay to things that make you uncomfortable. So hypnosis and its involvement with the dopamine system may work in part because your imagination is a very good way of giving yourself pleasure and motivating future behavior in the same direction.
Are there environmental factors that might make it easier to achieve a hypnotic state? Or, early ancestral shaman used hallucinogenic agents like peyote and other things to induce a trance. Do hallucinogens and other drugs have a role in hypnosis?
It's an interesting question. Certainly, the tradition of using hallucinogens. Every culture around the world has some mental state altering substance. Alcohol or peyote, as you mentioned, or psilocybin, or cocaine, or marijuana. And I think one way in which we as humans have evolved to adapt to a life that is often nasty, brutish, and short is to be able to change our mental state. And we do that when we go to sleep. You're just totally tied up with a problem that's driving you nuts when you go to bed, and the next morning you say, oh yeah, here's what I can do to deal with that. So mental state change of various kinds is a very useful stress adaptation strategy, unless you do too much of the mental state changing with some drugs. Certainly, some of the hallucinogenic drugs induce something that is trance-like. The difference is that your ability to control the state may also be impaired. One of the advantages of hypnosis is that you can alter your mental state. You can feel very different in a hurry, but you also can control it. And so the problem with some of the hallucinogens is you can change things, but you may not control them. There have been some very interesting recent studies of the use of psilocybin and MDMA in people with PTSD and also dying patients. It surprises me a little. I've reviewed some of this work, and some of it is very well conducted. And it suggests there are people who are dying of cancer who say that this use of psilocybin was one of the 5 or 10 most important experiences in my life, and I see death differently now, and it doesn't threaten me in the way it used to. So I think at a sort of meta level, there are some overlapping things about the two, but I do think that the kind of trance-like state you may get into with a drug is still somewhat different from hypnosis.
And we know that acupuncture can be blocked with opioid receptor blockers like Narcan. So are there any receptor blockers that inhibit hypnosis?
Very interesting question. We actually did a study in which we tried to block hypnotic analgesia with Narcan, with naloxone, 10 milligrams. And we found that it had no effect on the hypnotic analgesia. So you cannot block hypnotic analgesia with an opiate receptor blocker. I don't know. Any drugs that will sort of scramble your brain or reduce your control will inhibit hypnosis. There have been studies that show that if you give a benzodiazepine, like Xanax or Valium to someone who is not very anxious, you'll inhibit their hypnotic response because you partially sedate them. So drugs that kind of blunt attention will tend to block hypnotic concentration.
So you've talked about some different techniques with hypnosis. So which technique is generally most effective, or does it depend on the individual?
To some extent, it depends on the individual, the type of problem, and how hypnotizable they are. So highly hypnotizable people will tend to respond to a very direct instruction. Just imagine you're floating in a mountain lake, and the sensation will filter the hurt out of the pain. For less hypnotizable people, it's more of a negotiation, where you develop with them a strategy where they decide how to best approach modulating their perception of pain or their anxiety. There are many other hypnotic techniques that people use, but I think adjusting the type of intervention, the sort of style with which you introduce the intervention, to the degree of hypnotizability, the subject is often the most effective way to use it.
And so how long does the hypnosis typically last?
Typically, when I use it, people are in the hypnotic state for, 5 or 10 or 15 minutes, but they can induce it any time they want. A simple hypnotic suggestion, there was a study done many years ago in which Martin Orne took highly hypnotizable people, gave them 30 postcards and said, mail me one a day for a month. And it pretty much stopped after about a week or 10 days.
Gotta love that design.
The idea that you can just put the whammy on someone and they'll do it forever is pretty much not the case. So if you help people weave it into their own lives and use it with their own motivation to get better, it can last much longer.
Are there any notable potential hazards associated with hypnosis or its practice?
Well, sure. Hypnosis is a state in which you are suspending critical awareness. You're allowing somebody who may be pretty much a stranger to kind of reorganize your internal mental environment. And that takes a certain amount of trust. And it is also possible for people to have their perception of what's happening distorted. And so an unscrupulous person could get you to do something that is against your normal moral judgment because, in part, you don't realize what you're doing, or you feel that it's very important to please that subject. And in fact, one problem that highly hypnotizable people have is that they're so good at tuning into other people's needs and desires that they kind of forget their own. One of my patients described herself as a disciple in search of a teacher. And so what I have to teach them to do is to toughen up and not automatically respond to everyone else's needs before their own. So it can be an advantage to be such an empath and be so intuitively connected with other people, but it can be a disadvantage too. And unscrupulous people will take advantage of people like that. So yes, there are dangers, but it has not to do with hypnosis per se, but with how it's used and who uses it.
And that's true for so many things.
I was going to say, yeah. So, David, have there been any studies looking at molecular level changes that are associated with hypnosis? And also, do you have an animal model equivalent that you can use for studies of brain tissue specifically?
I don't know of any good molecular studies of hypnosis. I think it would be a good thing to do. There are some animal models of hypnosis. There's what's called the immobilization reflex. So if you put a steak in front of a chicken, it'll just stand there and look at the steak for a long time. I had a parakeet, they don't like you're putting your hands over their wings, but I would flip him over on his back and tickle his abdomen just below his thorax, and he would just lie there happily forever. So I think there are some animal equivalents to hypnosis, but as with all of these animal models of complex human states, they have their limitations. So I don't know of any good animal studies that have added much to what we know about hypnosis.
Speaking of animals, do we see what seems to you to be a true hypnotic effect in animals other than humans?
Well, I think, the closest thing are these immobilization reflexes.
Yeah.
There is a survival advantage to being able to not move if you're severely threatened or hurt, because most predators detect movement. They're motion detectors. And so and many predators don't like dead animals, they want living ones. So if, you can view hypnotic analgesia as a way of pretending you're dead even when you're not and you're in pain. And that probably has survival advantage. So I think the same is probably true with animals, and that's one reason we've evolved to have this ability.
Right. So you would see this as an evolutionarily conserved process, not necessarily unique to humans.
Yes, I would think so.
Over the years, you've worked with hospital physicians on ways to use hypnosis in addition to anesthesia in the operating room. And you've done a lot of work with radiologist Elvira Lang at Harvard. The two of you did a study, which was published in The Lancet, that found hypnotized subjects used less medication, experienced less pain, and felt less anxiety than other groups who weren't hypnotized. That's an amazing outcome. Can you talk to us about that?
Sure. Elvira Lang is a wonderful interventional radiologist. And she and I worked together to develop a hypnotic analgesia program for people undergoing invasive radiological techniques. So it's an arterial cut down. You thread a camera or you do chemoembolization through the arteries to the liver or elsewhere. And we don't use general anesthesia for that, but it's very uncomfortable. and often anxiety-provoking. And so we had 3 arms in the study. One was everybody got a button they could push that connected opiates to an IV, and they could push a button and deliver themselves a dose of opiates. The second group got that plus a friendly nurse just providing nonspecific comfort. And the third got someone trained in using self-hypnosis. And what we found was that the group, there were like 243 subjects in the study. By the end of 2 hours, the hypnosis group had a pain level of 2 out of 10, and the standard care group had a pain level of 6 out of 10. By the end of 2 hours, the hypnosis group had no anxiety at all. I was afraid they were dead. They just weren't responding, and it was like 5 out of 10 for the standard care group. They had far fewer complications. They used half the pain medication. And maybe the most striking thing is that the procedures took 17 minutes less time to complete. And what Elvira noted was that the staff felt better because the patients seemed so comfortable. They didn't feel like they were inflicting a lot of pain on them. So this provided clear evidence that patients who were taught self-hypnosis during these procedures were more comfortable, less anxious, had less pain, and got through with them quicker with fewer complications. Now, if you published a study, a randomized trial like that of substantial size in The Lancet, with results like that, and what you were using was a drug, every hospital in the country would be using it now. But this was hypnosis, and is every hospital in the country using it? No.
All right. I was going to say, and even Dr. Lang has gone on to bolster those findings with 2 other studies involving more than 300 patients that show that the patients who are hypnotized used less medication, recovered faster, and spent less time in the hospital. Is that right? There's just a continuation of studies?
Absolutely right. There's a series of studies, and we did the same thing with children undergoing a painful procedure in which they have their bladder imaged. So you have to insert a catheter in an 8-year-old child, have them hold their bladder full and then pee and see whether there's reflux to the kidneys. And we got the same 17-minute reduction in the procedure length, which for an 8-year-old child, you can imagine, means a great deal. Dr. Lang has gone on to develop a program she calls Comfort Care that she's trying to teach hospitals to use. So she's trying to make it happen to help patients get through these difficult procedures with less pain and more quickly.
And David, I was going to say, despite your research and years of these rigorously controlled studies that have shown hypnosis reduces pain and controls blood pressure and is effective for treatment of things like phobias and eating disorders, a lot of scientists and physicians remain skeptical of hypnosis, like you've mentioned. So why do you think that is?
Because they're flaming idiots. No, I'm not. It's, there's this kind of prejudice that comes from the old, mystical, purple cape, dangling watch idea of hypnosis. I understand that people just, but there's something else. And that is, we have this reductionist biological exceptionalism that the only real science and the only truly scientific treatment is bottom up, sort of like fixing a car, replace the parts or, plug in a drug or operate. And that teaching people to use their brains better, to manage their bodies isn't a real treatment. And people dismiss it in one of 2 ways. They either say it doesn't do anything or it's terribly dangerous, And I can tell you this, I've used hypnosis, as I said, with 8,000 or 9,000 people. I have never had any of the complications that I see with the medications I use with patients. It's much safer than anything else we do in medicine. And I find it very frustrating that people continue to be prejudiced against a technique that can be so helpful and is so relatively safe compared to most of the other things we do. And one particular example that's very disturbing now is that, there have been 300,000 people killed in opiate overdoses since the late 90s. More people die now of opiate overdoses than of the combination of gunshot wounds and auto accidents in the United States. 1/4 of all people with private health insurance have 1 opiate prescription a month. We're just infested with opiates, and now fentanyl, which is hundreds to thousands of times more potent, is killing more people. And doctors are prescribing a lot of this stuff. And techniques like self-hypnosis are so much safer for dealing with pain. Opiates are great for acute pain, but they're very dangerous for chronic pain. And so it's really a shame. The Joint Commission now is going to have new guidelines requiring that for hospitals to be approved starting next year, they're going to have non-pharmacologic pain treatment programs. And so approaches like hypnosis and acupuncture are going to be required in hospitals to get accreditation, which is a good thing. But we are overlooking this very effective resource for pain control.
Absolutely.
Turning to a slight shift here in context, have folks done research on the efficacy of hypnosis in the context of elite sport or Tier 1 military units. For example, with respect to recovery or overtraining. In particular, I was wondering about whether there's any research on hypnosis and heart rate variability.
Interesting questions, Ken. I know about elite athletes. There is a literature on hypnosis in sport, because a lot of performance at these very high levels is really more of a mental game than a physical game. People have to prepare physically, but the ability to concentrate on what matters is the most important thing. Tiger Woods, when he was starting his career, was training using self-hypnosis, and what's happened later in his career is rather sad, but he was famous for his ability to just stay cool at all times and overcome, setbacks and just maintain his concentration. Ken Norton, when he broke Ali's jaw, had been training using self-hypnosis. A lot of the Olympic athletes at the Sochi Olympics, one of Putin's many wonderful ideas was to put the Winter Olympics in a place that had hardly any snow. And they couldn't practice more than one run before they actually had to do the run. So they would go up to the top of the ski hill and do what looked to me a lot like self-hypnosis. They'd roll up their eyes, close them, and just do the run mentally. And they said it was tremendously helpful to them. So the idea of using hypnosis is sort of mentally program yourself to do what you need to do and avoid distractions. The Stanford women's swimming team came to me years ago. They were superb swimmers, and the coach noticed that they got better times in practice than they did during meets. Normally you'd think it'd be the opposite, but they were so distracted by the competition that they weren't swimming their best races. So I was teaching them to do self-hypnosis, to just swim their best race in their head and not worry about what else was going on. I don't know of any studies in the military. It wouldn't surprise me. I know they're doing resilience training, and there have been some attempts at mindfulness for combat troops, but I don't know anything personally about that. I think there was one other aspect to your question.
Yes, heart rate variability. I'm wondering if that could be improved via hypnosis.
I would think so. I don't know of any specific studies. Heart rate variability is a very good measure of what's called vagal tone parasympathetic activity, which is a self-soothing capacity we have to reduce sympathetic arousal and just calm ourselves. People with higher heart rate variability are more likely to survive a heart attack. We've recently shown that they live longer with advanced breast cancer as well. So it's a very important physiological parameter. I don't know of any studies in which the effects of hypnosis have been related to that, but it would make a whole lot of sense that it would be.
Yeah, that would be very interesting, both for health, sport, and also for the military, I think.
So, David, tell us about some of the ongoing areas of research in your field.
Well, there are certainly more clinical trial kinds of studies trying to study the effects of adding hypnosis to treatment for a variety of physical and psychological problems. There's some recent work adding hypnosis to mindfulness. So seeing whether the combination of the two, using hypnosis to enhance mindfulness, may help. Because hypnosis isn't in itself a treatment. It's a state of attention and concentration and consciousness that can be used to facilitate a variety of other treatments, cognitive behavioral therapy or acceptance and commitment therapy. You can intensify it by adding hypnosis. And there are techniques like dialectical behavior therapy that have been extensively studied that involve self-awareness training that sounds to me a lot like self-hypnosis training as part of DBT. So some of it is that. And then there are the neurophysiological studies trying to look at similarities and differences between hypnosis and mindfulness, hypnosis and placebo, like the question you asked earlier. So I hope we will continue to accumulate evidence about the neurophysiology, and that if we understand that better, people will get over this prejudice that just using the mind is not a fundamental neurobiological phenomenon, because I'm convinced, and we have plenty of evidence, that it is.
And you had mentioned your studies on fibromyalgia and breast cancer patients. Are there any other large-scale ongoing clinical trials that address hypnosis as a potential therapeutic approach?
That's a good question, and I don't know the answer to that. I don't know of any other large-scale trials going on at the moment. There may be, but I don't know. I think Dr. Lang is continuing to do some studies in the hospital setting, look at the effects of hypnosis on intervention along the lines of her previous research, but I don't know of any others.
Have there been any notable successes in the use of hypnosis to wean addicts off of drugs or alcohol?
The single biggest success area is smoking control. And that's not a minor problem, and people are more and more concerned about nicotine addiction. The fact is that the nicotine replacement approaches don't work all that well, and the drug companies renamed bupropion to try and market it for smoking control, and the results are not that exciting. We did a study some years ago in which we used a single session of self-hypnosis to teach patients to focus not on fighting smoking, but rather to focus on respecting and protecting your body, to treating your body the way you would treat a child or a pet, and not put poison. And it's funny when you think of it that way, but if you took a can of dog food out of the cabinet and it said, "Warning, the Surgeon General has determined this is dangerous to your dog's health," would you feed it to the dog? No. But people do the same thing with their own bodies because they say, "Well, I'm doing it to myself." Well, you're not. You're doing it to your body, and you will eventually pay the price, but you're doing it to your body. So we teach people to use self-hypnosis to deal with the impulse to smoke. And we found that half the people we give a single session of self-hypnosis to will stop smoking, and half of them won't touch a cigarette in 2 years. So we get 23% long-term complete abstinence from smoking after one session, which is better than just about any other treatment for smoking control. I've had some clinical success with a few people with alcohol and drug addiction, but the problem there is that they're clouding their consciousness while they're abusing. And so that makes it harder for them to use self-hypnosis. But it may be a better technique for consolidating abstinence than for initiating abstinence.
There appears to be a renaissance in medicine built from two metaphorical houses. The first, composed of the powerful but often limited reductionist parts and pieces approach, which has provided enormous details to the inner working of biology, but has been perhaps somewhat lackluster in providing application to broader, more chronic conditions that we see all around us. The other house is a recognition of the need for a systems-based approach to biology and ecology, particularly one well steeped in the principles of Darwinian evolution. Given all of this, can you speculate about what might be the evolutionary imperatives that brought about the ability to experience hypnosis? What is its purpose, in a sense, or its selective advantage?
Well, one thing that the evolutionary perspective allows us to think about is, what are humans' adaptive advantages? How did we manage to survive and to spoil the planet the way we did? And because, we're pathetic physical specimens. I mean, there are, cheetahs can run 65 miles an hour. Birds can see a whole lot better than we can. Dogs can smell better than we can. And the only evolutionary advantages we have are the opposing thumb, which is a good thing, and this large brain that sits on our shoulders. And the brain allows us, to form social connections. So we're very social creatures, and we would not survive without social support. The human infant is the most dependent creature in the first year of life, so it will not survive without forming a connection with parents and other family and kin. And so we depend upon one another to survive. But the other thing is that we have this brain that allows us to detect danger, but react to danger and react to harm. And so I think one of the tragedies in modern medicine is that we don't pay attention to and take advantage of what our major evolutionary advantage is, which is our ability to manage what we do with our bodies and what we perceive. And so we're so focused on an acute care model in modern medicine where we want to diagnose the problem and fix it, replace the part, new knee, new hip, or give a medication. And I do that too. I prescribe meds, but it's not the only thing that I do. And I think we have overvalued acute interventional medicine and undervalued chronic care and the type of treatment that teaches people how to better manage the condition that they're in. And that, the palliative care movement is a good example of that. The growing interest in mindfulness is, and certainly hypnosis is. And, the oldest adage of medicine is that our job is to cure rarely, relieve suffering, and comfort always. But with the Flexner era at the beginning of the last century, where we in a good way, made medicine more of a science and less of a trade. We also changed that motto to be that our job is to cure always, relieve suffering if you have the time. And I think that's just a tragic mistake. We've painted ourselves into a corner. And you know what? No matter how good medicine gets, the death rate is always going to be one per person, So sooner or later, we're going to lose that battle. And the idea that all we're there to do is to fix the biology and cure people leaves out most of what real medicine is all about. And so there's a lot we can do in both the acute care setting and in chronic care to help people use their brains better to live better lives.
Indeed. I was, my own research is mostly in AI, and I was just at a meeting where some physicians were complaining that these darn machines were going to take their jobs and that they could do diagnosis better than they. And it seems such a limited and demeaning view of what a good physician provides. Mm-hmm. It's not just running statistics and asymptoting on a diagnosis, but it's so much more.
That's absolutely right, Ken. It's absolutely right. That, whatever it is, you could have said that, with the early lab values or, would textbooks replace doctors? No. Patients, will need to rely on someone who has more experience with the disease than the one they just got, than they have. And they'll need help in navigating that course. And that's what people care about, is having someone who says, I'll be there with you and I'll help you deal with it. That's what medicine should be all about.
So as we're talking about the medical system and the medical profession, what are your thoughts on the likelihood of insurance companies starting to support hypnosis therapy?
Well, there is a billing code, 90880, and I sometimes get paid on that code. I certainly have had, companies refuse it, or my staff tells me, call it psychotherapy, don't call it hypnotherapy, or you won't get paid. What you have to realize is that techniques like this are just dirt cheap compared to most of what medical care is about. Half of our healthcare dollar goes for hospitals, a quarter goes to doctors, and a quarter, I'm sad to say, goes to insurance companies, which is a almost complete waste of money. It may be interesting to note that the slick, mean private insurance system, their overhead rate for managing healthcare dollars is 27%, so more than we spend on doctors. The horrible, inefficient government healthcare system, Medicare, their overhead rate for managing care is 2.7%. So Medicare is 10 times more efficient at managing care than private insurance. And that's why they couldn't stand the public option. They called it unfair competition. It isn't unfair, it's just better. There are times when government does things better than private industry. So part of the problem is that the insurance industry has fueled an inflation in healthcare costs. And if you think about it, they make money while it's flowing through the pipeline. So if I could reduce healthcare costs in America by 50%, they'd find me and kill me, because the more it costs, the more money they make. The idea that it's the fox guarding the hen house, the idea that they're going to try and lower healthcare costs is ridiculous. So frankly, one thing they don't like about hypnosis is not that it's an added expense, but it actually eliminates other much more expensive things that they can claim they cover. That's the real problem.
Well, this was great fun, David, and thank you for the fascinating discussion on a really remarkable topic. We appreciate you doing this.
You're most welcome, Ken and Dawn. I was happy to do it.
Time just flew by. It was a really good discussion.
Maybe we've been under his spell. We've been mesmerized.
STEM Talk. STEM Talk. STEM Talk. STEM Talk.
So this is a really cool interview with David. The potential applications for hypnosis seem so far-reaching, and it sounds like David has a long line of research ahead of him for conditions such as PTSD and fibromyalgia, cancer therapy, and pain management, among many other conditions that would benefit from hypnosis. That was such a fascinating discussion.
Yes, Dawn. David is truly a pioneer of a therapeutic approach that, funny enough, has long existed in the history of medicine. It's so great to see him studying hypnosis using modern medical applications, tools, and methodological clinical design. A very promising approach for a large number of conditions indeed. His evening lecture at IHMC was every bit as intriguing as his appearance here on STEM Talk.
And we'll make sure that we include a link to that evening lecture. And if you enjoyed this interview as much as we did, I invite you to visit the STEM Talk webpage, where you can find the show notes for this and other episodes, stemtalk.us. This is Dawn Carnegie signing off for now.
And this is Ken Ford saying goodbye until we meet again on STEM Talk.
Thank you for listening to STEM Talk. We want this podcast to be discovered by others, so please take a minute to go to iTunes to rate the podcast and perhaps even write a review. More information about this and other episodes can be found at our website, stemtalk.us. There, you can also find more information about the guests we interview.